Good morning, Ms. Kofke here, coming to talk to you today about continuing tissue integrity. So this is part 2. If you haven't watched part 1, please go back and do that. In part 1, we talked about just an overview of skin alterations. We also went over diaper dermatitis and moisture-associated skin damage. So now in part 2, we're going to talk about wounds. We'll talk about types of wounds, wound healing, and some complications of wounds. So this information is on page 1048 in your fundamentals book. So I would suggest you review there. Some of the types of wounds you'll see. So here we have, let me get my pencil out. Okay, oh, let me change colors because the screen isn't going to show up good. Okay, so here we have an incision. So this would be a wound that was cut on purpose. And we see the edges are approximated, or all those edges are together. Contusion, skin is intact with a soft tissue injury due to a blunt instrument. So basically, we're talking about a big bruise here. Abrasion, an abrasion is going to be a superficial wound where the skin, those top layers of skin are torn away. So things like, just like this, skin to knees, things like that is an abrasion. Laceration is a tearing of the skin and tissue with an irregular instrument. So an incision would be an instrument that cut across. A laceration is where the skin was torn or cut by an irregular, by an object, and the edges are irregular. So you see the difference there. A puncture wound would be a blunt or sharp tearing of the skin after breaking through. So something sharp put through the skin. So this looks like an animal bite. So that those teeth going straight through the skin. Penetrating wound is when a foreign object enters and lodges in the tissue. An avulsion is a tearing of the skin or membrane from its normal position. So it's not just a skin tear. It also includes subcutaneous tissue or other tissue and can lead to nerve or vessel damage. So like you see this, it's deeper. The skin is torn, but it's more than just that top layer of skin you would see in a skin tear. Microbial would be from secretions or release of toxins from an organism. So here are some more types of wounds. Again, these are on page 1048 in your book. So chemical would be when a toxic agent has been released and led to cell death. So we see a chemical burn wound here. Thermal injuries, so sunburn or any type of a burn, but thermal would include frostbite as well, which we see here. Irradiation is from UV light or radiation exposure. This would be from radiation treatment from a cancer. That's the type of burn that we see here. Pressure injuries, we will spend a lot more time talking about, but a pressure injury is due to compromise in circulation due to pressure, but we'll have part 3 of tissue integrity is going to be basically just about all about pressure injuries. So we'll be talking more about that. Up here we have venous ulcers. So a venous ulcer is due to poor blood return and injury or incompetent valves leading to an obstruction in the blood flow. When you're looking at arterial versus venous, one of the things you'll want to look at is the surrounding tissue, is what all that peri-wound tissue looks like. With a venous ulcer, you'll usually see more of a darkened discoloration of the skin because that there's no venous return, there's poor venous return. So what you see is that blood is pooling. So you'll see that darkened discoloration. Where down here we have an arterial ulcer, which is due to poor blood flow getting to the extremity. So ischemia could lead to that. So when you look at that area around the wound, we see the skin is shiny and pale. We see, you'll see a loss of hair growth in that area a lot of times, but we're going to look for signs of poor perfusion here. We've got venous pooling with the venous ulcers, and then with arterial ulcers, you're seeing signs of decreased blood flow getting to the area. So pale skin, decreased or absent pulses, skin's shiny, all those signs of that there's not a lot of blood flow getting there. So think of it that way. With diabetic ulcers, these injuries are related to diabetic neuropathy and are also will be contributed by a less blood flow getting there and poor wound healing. There's a few ways that we can classify wounds. First up, we can look at intentional versus unintentional. So intentional is going to be exactly what it sounds like. It is some sort of planned therapy or treatment. The edges are clean. So we're thinking of like surgical incisions. Remember, when you start IVs, you are breaking skin integrity. You are entering into the skin. So things like that. Unintentional would be unintentional, right? So accidents, injuries, burns, things that are were not intended to happen. So with unintentional versus intentional, typically an unintentional injury, it's going to be probably in an unclean environment, done not sterilely as you would with a surgical incision or starting your IVs. So the edges are going to be more jagged. So you're looking at increased risk of infection, increased healing time, more likely to bleed, more difficult to control the healing process with these unintentional injuries versus when we purposely have disrupted our skin integrity. Next up, we have open or closed. So again, just what it sounds like. So an open injury would mean the skin is broken. So you've got some tissue damage, increased risk of infection and bleeding. Remember that skin's there to help protect against infection and things. So if you have an open wound, you're going to be at greater risk for infection. A closed wound would be when the skin is not broken, but there's damage to the underlying tissue, like a contusion or bruise, or an internal injury from a fall or a motor vehicle accident. Acute versus chronic. An acute injury is a new wound that typically is going to heal within days to weeks. A chronic wound is slow healing, it has an increased risk for infection, and is taking weeks to months to heal. Partial versus full versus complex. So a partial injury would include all or part, mean that all or part of that dermis is intact. A full, that full level would it mean that the entire dermis is affected. So with partial, you're talking epidermis and just part of the dermis. Full injury, full thickness injury would mean that the entire dermis, that lower level, is affected. And then a complex would mean that the damage and destruction goes beyond the dermis and into that subcutaneous tissue or below. Remember that where your client is at is going to impact their risk of alterations in tissue integrity and also how quickly they may heal. So in an acute care setting, a pressure injury will usually develop within the first week of hospitalization. So skin assessments need to be done on admission in every shift, and anytime there's a change in condition. In an ICU setting, pressure injuries can develop within that first 72 hours. So again, constantly assessing and looking for alterations in tissue integrity. In the OR, clients are at risk due to prolonged immobility. If you've got somebody having a surgery that takes several hours and they're not moving at all, there's no turning and all that in the operating room. So that's going to be, they're going to be at higher risk for a pressure injury due to that decreased perfusion and positioning. So that is what happens there. Long-term care skin assessments need to be done on admission, weekly, and with any change in condition. And then home health will need to do it on admission and every visit. So let's talk about wound healing. So we're going to talk about the different phases in wound healing. So remember that all clients are different, and in each phase, you may have a delay in healing depending on what's going on with that patient. So the first phase of wound healing is going to be hemostasis. So in hemostasis, those local blood vessels, if you have an injury, those local blood vessels are going to constrict, and platelets are going to be activated to start that clotting process. Now, you'll also have those vessels will then dilate to an increased capillary permeability. So remember that inflammation that when we talked about inflammation, think about that inflammatory process, damage to skin tissue, starting that inflammatory process. So increased capillary permeability. So plasma and parts of the blood are going to leak out of the vessels and into that injured area, leading to that exudate. It's going to cause that swelling and increased pain, increased blood flow, heat, redness. Think about that inflammatory response. And then the platelets are going to come in to help. If the wound's small, it's going to scab over and dry, and then that scab is going to protect from infection. So symptoms during this first phase of wound healing, you're going to see that that basically the side effects of that inflammatory response. So the swelling, pain, redness, you may have exudate accumulate from the white blood cells and the leftovers of trying to capture anything that doesn't belong there. If your patient has poor perfusion, then they're going to not be able to heal as well. So if you have an injury, those blood vessels are not, without the perfusion, all those white blood cells and the platelets and all those things aren't getting there as quickly as they need to. And for that matter, if your patient had low platelet levels, then they're not going to be able to clot off and form that protective scab as quickly as if they did have a lot of platelets. And same for your patients that are on anticoagulants. They're not going to be able to get that hemostasis as quickly. The second phase is going to be this inflammatory phase. So in phase one, we see that beginning of that. So the beginning of the inflammatory phase, those vessels opening up, getting the platelets going, getting hemostasis. So when we talk about hemostasis, we're talking about that there's not bleeding anymore, right? So platelets are getting there, scabs forming. And then now in phase two, we're going to look at that inflammatory response. So in the inflammatory response, during this inflammatory phase, we're going to see the removal of a foreign substance and preparation for healing. So this is just exactly like what we talked about in inflammation. So lasts a few days generally. Neutrophils, macrophages move in, eat, and destroy, and get rid of the things that don't belong there. We're going to see growth factor release. So the purpose of that is to help aid in producing those new skin cells, and then we'll also attract fibroblasts, which are going to move in and will also, you'll see that redness, swelling, heat, pain, decreased function. So all your cardinal signs with inflammation. Inflammatory phase, you're looking at this inflammatory process going to work. So you may see that localized effect. So the redness, swelling, heat, pain, decreased function, or those systemic effects of inflammation. So mildly elevated temperature, increase in white blood cell count, and that generalized malaise. So again, think about alterations if your patient had a decreased immune response. If they are immunocompromised or have fewer white blood cells, they are not going to be able to respond in the same way. So next up, we have the proliferative phase. So this is when we are building new tissue and filling in the wound space. And this usually lasts several weeks. Fibroblasts are a type of a connective tissue. So they're going to make and secrete collagen and growth factors to make new blood vessels and to keep bringing all the oxygen and nutrients to that wound bed. So they're going to attract those endothelial cells and try to get them to grow and move in there and help with that healing process. So those fibroblasts join with the endothelial cells and make granulation tissue. So, and we'll talk more about granulation tissue when we talk about pressure injuries and what that wound bed should look like. So that granulation tissue is it's soft, it's fragile, it's where the healing's happening. So if it's good, it's going to bleed easily because it's going to be highly vascular. It begins at the outside of the wound and moves in towards the center. And it's going to create that base for your scar tissue to form. So collagen is going to be continued to make. For large wounds, this may take anywhere from weeks to years. It's going to depend on the size of that wound. So, but that collagen is going to increase the strength of the wound so that it can heal over and continue to be protected. So important aspects of this proliferative phase. So with this proliferative phase, just really think about everything's kind of regrowing. So you're beginning that to get ready for that scar tissue, which is going to happen in our next phase. But think about everything's just kind of growing. You're getting all your new tissue. You got that granulation tissue, all that. That's hopefully all that highly vascular and bringing all your nutrients and oxygen in to keep that healing coming from the outside in. So if some things that are going to be important to think about is your patient's nutrition, how well they're oxygenating, because those things are going to be important right now in this healing phase. If you have edema, poor blood flow, poor nutrition, then all this healing is going to be harder. It's going to be more difficult for those things to take place. Our fourth and last phase is the maturation phase. So this could take anywhere from weeks to months. And this is when that final scar tissues form. The wound closes or contracts and the tissue's drawn together. The collagen will help make it stronger, just like in that surrounding tissue we talked about, and that scar is going to form. After that scar tissue's there, it loses its blood supply. So scars don't sweat, they don't have hair or pigmentation. It is strong tissue, but it is also less flexible. Also, when we talk about wound healing, we'll talk about intention. So primary intention is when you see wounds that will heal by sealing off the outside. So a scab forms on the outside, and then healing happens underneath the skin. It begins in that wound bed after it has healed on the outside. This type of healing, the epidermal cells will move across the top, seal the wound within 24 to 48 hours, but then it isn't all the way healed underneath. It'll continue healing underneath. Examples of this would be like a surgical incision with staples or stitches across the top. Also, if you just got a cut on your hand and that scab would form over the top, and then the healing would continue underneath. Secondary intention happens with larger wounds, and has that scar tissue formation and granulation tissue forms on the inside of the wound, and the wound heals from the inside out. So things like pressure injuries or larger wounds that are open, they'll heal from that inside, and that granulation tissue forms and it heals from the inside out. That scar tissue slowly forms on the way out. Tertiary healing is a delayed primary. So this would be if somebody had an infection or severe edema, and you couldn't get a good closure. You needed that healing on the inside first. So then they may leave that wound open. So for several days to allow that edema or infection to resolve and then surgically close it for a primary intention healing. So let's look at some factors that will affect wound healing. So pressure is going to decrease blood flow and delay healing. So anytime there's decreased blood flow, that is going to delay healing. If there is dehydration, those cells will dry up and die and cause a delay in healing. Overhydration or maceration will also delay healing. It increases bacteria and can cause erosion there at the site from friction. Trauma will also affect the healing process. Edema decreases effective blood supply, so decreases the nutrients and oxygen getting there. So like I said, anytime there's decreased blood flow, going to have decreased healing. An infection will also decrease infection time. It's going to have bacteria. The bacteria will release toxins. There's increased energy expenditure in your body, so that will delay healing. If necrosis has happened and there's dead tissue, that will also delay healing, and that dead tissue will need to be removed in order for healing to happen. When we look at for that necrosis, things we'll look for slough, so yellow, stringy, moist type material, or eschar, which is dry, black or brown, or leathery looking tissue over top of a wound. Children lose the connection between their layers of skin, and then older adults have decreased fibroblast activity and decreased circulation. So that may affect healing time. Biofilm is when bacteria creates a film in the wound bed, and that will delay healing. Just like I said, circulation. Anytime circulation is impaired, oxygen is needed for healing. If your patient is obese, that increased adipose tissue can be more difficult to suture in an intentional wound, and will have increased risk for infection. Chronic conditions like heart disease, peripheral vascular disease, hypertension, anemia. So remember, less oxygen carrying cells, lung disease, or smoking, things that will decrease that oxygenation. So when you look at the chronic conditions, anything that's going to alter nutrition, perfusion, oxygenation, those chronic conditions are going to impact wound healing. Overall nutrition, remember we talked about you need the calories and protein to rebuild cells and tissue. Vitamin A or C are important for building collagen. Zinc helps to make cells as well, helps with healing. The wound condition. So is it large? Is it small? Is it infected? So things like that. Medications like corticosteroids, chemotherapy, or antibiotics may impact wound healing. Remember, we talked about in immunization, if your body has a decreased ability to with white blood cells and things like that, to go after and lead to this healing process, you're going to have a delay. So anything, chronic conditions like AIDS, lupus, if you're on chemotherapy or having cancer, that will lead to immunosuppression and also delay wound healing, because your body's just not able to recognize and replace all those cells whenever they aren't able to recognize. That kind of tears down that whole process. All right, so let's start talking about what we're going to be assessing and looking at for clients that have alterations in skin integrity and have wounds present. Developmental considerations, think about for your pediatric population, if they're in the hospital, we often have treatment rooms for them, because you don't want to do dressing changes and things like that inside the patient, inside their room. We want their room to be a safe space for them. Elderly patients, just thinking about all the alterations in immunologic function and things like urinary incontinence that could lead to maceration in that area. So all the different things when we look at changes in the older adults that could also impact wound healing. Again, nutrition is going to be super important. So we're going to assess their weight, how well they're eating. Do they have teeth? Are they able to chew and swallow? Are they able to attain food? Remember that they need protein, glucose, vitamins, minerals, and trace elements in order to optimize wound healing. So vitamin A, B, C, vitamin K is going to be important for the for that process as well. It has to do with the prothrombin and being able to create homeostasis there at the site. So encouraging high protein, calories, proper hydration in our clients, because remember, hydration is also going to impact that. Lifestyle, how are their home conditions? Who's going to do dressing changes at home? So things to look at. Maybe adding multivitamins to their diet. And then just like we talked about on the last slide, are there medications that this patient's taking that are going to impact healing, as well as like steroids or chemotherapy? And then also, is there anything that we can do to improve nutrition if our patient is unable to eat? Like starting tube feeds or TPN, you'll talk about later, parenteral nutrition. Can they get nutrition through their IV if need be? So let's look at wound complications. So one of the first things that's going to be hemorrhage. So if you have a disruption in the blood vessels, you're going to be at risk for bleeding. Remember, our patients that have low platelet counts or are on blood thinners or anything like that are going to be at risk for hemorrhaging as well. So we want to make sure we're checking the wound and dressing frequently, checking drain output. And we'll talk more about drains when we talk about caring for the wounds, but checking the drain output, looking for bleeding. If you see bleeding, you need to apply a pressure, hand pressure, put in a pressure dressing. You'll want to get some stat labs. Generally, you'll need to call the physician. Typically, we'll order things, hemoglobin, hematocrit. Also might look at some of your coagulation studies, PT, INR, PTT, things like that. You will need to do some fluid replacement, possibly blood administration. And then typically these patients are it's going to be an emergency. They're going to need to get back to surgery. Your patients, anytime that there's a break in tissue integrity, those wounds are going to be at risk for infection. So which types of wounds do you think will be at a higher risk? Think about things if that wound happened due to trauma or in a contaminated area. So an unintentional wound is going to be higher risk for infection. If there was some sort of a bowel surgery, anytime you're talking about intestines or GI stuff, you're going to look at high risk for infections. If you've got a wound that is on your lower back, you've got a patient that's incontinent of stool, that's going to be a big risk. Open wounds. The more open, the more opportunity for bacteria to get in there where they don't belong. So typically signs and symptoms of infection may appear 2 to 7 days after an injury or surgery happened. So we're going to be looking for signs and symptoms of infection. So purulent drainage. So not the serous, not the clear yellow, but purulent, meaning it's got some old dead tissue, white blood cells, things like that in it. So maybe yellow, white discoloration. May see an increase in drainage, pain, redness, swelling. So localized signs of infection. because remember, infection is going to start off that inflammatory process. So you'll see those localized signs of inflammation that are because of that infection. And then you may see systemic things like an increased white blood cell count, and you may have a delay in wound healing. Another thing is that infected wounds can spread to the bone. That infection can get into the bone, which is then called osteomyelitis, and it is very difficult to treat then. And then if it gets into the blood, can lead to sepsis, or just where that bacteria has gotten into the bloodstream. And so you see major systemic effects. Next wound complication is dehiscence. So that is going to be what we see here. So partial separation of the wound layers. The edges are not approximated. Remember, approximated edges means they're all touching. So dehiscence is when these wound edges are not touching. And then next up is evisceration. Evisceration. So evisceration is when the wound completely separates and underlying organs or coverings protrude. I have seen this before. It's an emergency. If your patient has evisceration, then you need to cover it with sterile towels. You want to use wet sterile towels. You want to saturate not saturate, but wet the sterile towels with sterile saline. If you put a dry covering over this wound, it is going to dry out that tissue. We do not want that tissue dried out because that can lead to cellular death. So wet with sterile saline, sterile towels, and this is a medical emergency. We want to stay with our client, call the healthcare provider. This patient is going to the OR. We cannot leave their organs exposed. So this is a medical emergency. So wet, sterile, covering, stay with your client, call the healthcare physician, keep them in a low Fowler's position, and they will be going to the OR. So who is at risk for dehiscence and evisceration is going to be patients that are either obese or malnourished. Smokers are going to be at higher risk for evisceration and dehiscence. People who are on blood thinners aren't getting that homeostasis they need, infected wounds, patients. And when we look at dehiscence and evisceration, I always think of abdominal wounds. Those abdominal wounds are just at higher risk. There's a lot more pressure. So if anybody's coughing a lot or straining or having excessive vomiting, you're having increased pressure in that abdominal region, and those abdominal wounds are going to be at risk for evisceration or dehiscence. So then lastly, we have fistula. So, and we've got that shown here. So a fistula is going to be an abnormal passage from an internal organ, from in the organ and then and outside to another organ. So it's almost like a little fissure happens, a little pathway, an abnormal pathway happens. So typically you'll have, what happens is an abscess will be created or a pocket of infected fluid that creates increased pressure, and just an abnormal path is created. If this happens, it's going to lead to delayed healing. If you have a fistula going into an abdominal GI area, you're going to be at very high risk for infection, because then you've got bowel content and things, electrolyte imbalances, dehydration, and skin breakdown that can occur. So again, we have our, let me erase my drawings. We have our alterations in laboratory values. This is the same slide we had in part 1 as well. So how did different alterations in lab values affect our tissue integrity and healing? So remember, elevated white blood cell count could tell us there's an infection in the wound. A decreased white blood cell count tells us that there's going to be a decreased ability to fight off infection and respond to that, to alterations there. Low WBCs or not WBCs, low hemoglobin or hematocrit, you have less oxygen carrying cells, so decreased wound healing. If your patient has decreased platelet count, it can lead to longer time for hemostasis to occur, prolonged healing. Remember, with our albumin, prealbumin, total protein, we are looking at nutrition. So decreased nutrition, decreased healing. With blood glucose, if it's high, that may impede circulation and delay wound healing. And then if your BUN or creatinine are altered, it could be a sign of dehydration, and you need adequate hydration for wound healing. So that's going to wrap up part 2, where we're just looking at wounds and wound healing. If you have questions, please post them to the forum or send me an email. In part 3, we're going to talk about pressure injuries.